Good afternoon, everyone. Let me introduce my 3-month progress report. My PhD topic is pathophysiology, diagnostics, and prognostics of acute illnesses. I'm a first-year PhD student and emergency medicine resident at Semmelweis University. My supervisor is Pánk Fenyves, and my scientific methodology supervisor is Fanny Adél Mesnerics. My vision is to improve the management of patients with acute illnesses presenting in the emergency department, and my mission is to contribute to the development of already existing guidelines. Here's an overview of my presentation. I have 2 ongoing projects right now. The first one is investigating rapid molecular assays in the diagnosis of bloodstream infections, and the second one is investigating the effect of ClotPro, a viscoelastic method, on blood products used in patients with gastrointestinal bleeding. Both of my projects started this autumn. So my first project is investigating the efficacy of rapid molecular assays in the diagnosis of bloodstream infections. So a little bit of the background. Sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. It can be diagnosed when there is evidence of severe systemic inflammation and the documented or presumed bloodstream infection. So 49 million cases of sepsis occur, causing 11 million deaths each year. So it is important to know that early management with adequate antimicrobials and rapid resuscitation strategies has been shown to be associated with improved outcomes. Blood culture is the gold standard for the diagnosis of bloodstream infections. However, these tests have a long turnaround time. To resolve this problem, there are already existing rapid molecular assays that allow earlier pathogen detection and identification, which can be classified as tests performed on positive blood culture and tests performed on whole blood samples. And this way, a shorter turnaround time can be achieved. So my clinical question is, what is the diagnostic accuracy of rapid molecular assays for bloodstream infection? Here you can see my PICO. We would analyze data from patients with suspected bloodstream infection. The index test would be these different rapid molecular assays performed on directly on whole blood. And the reference test would be the conventional blood culture. So our hypothesis would be that the diagnostic accuracy of rapid molecular assays is non-inferior to conventional blood culture tests. So the systematic search was conducted in 4 databases on the 20th of November, and here you can see the search key below. And here is the flowchart of selection. There we found 152 eligible articles based on the title and abstract selection, and now we are working on the full text selection. My second project is investigating the effect of ClotPro, a viscoelastic method, guided therapy on blood products used in patients with gastrointestinal bleeding. It's a retrospective matched cohort study. So bleeding from the gastrointestinal tract and its management is associated with significant morbidity and mortality. The incidence of upper gastrointestinal bleeding is 67 per 100,000 population, while that of lower gastrointestinal bleeding is 36 per 100,000 population. Viscoelastic methods, such as ClotPro, provide a rapid assessment of coagulation and can facilitate a more accurate targeting of therapy compared to conventional laboratory tests alone. And there are already existing guidelines which recommending the utilization of viscoelastic methods in trauma patients and in patients with perioperative bleeding as well. So the evidence of the benefit of using viscoelastic methods in massive gastrointestinal bleeding does not exist, but the benefit from the trauma research can be extrapolated. So our aim in this study is to observe the differences in the management of gastrointestinal bleeding using this device, the ClotPro. So the clinical question is, does the use of ClotPro influence the management of gastrointestinal bleeding patients in the ER? For the PICO, we would include patients with gastrointestinal bleeding. In the intervention group, there would be patients where ClotPro was performed. The comparator group would be the matched cohort, so the patients where ClotPro was not used. And here you can see the primary and secondary outcomes. And the hypothesis of this study is that the use of ClotPro optimizes the number of blood products transfused. Yes, oh, I see, the exact same. So a little bit about the data we are using. It's from Medsol, exported into Excel sheets. It seems a little bit complicated, but here each row means a presentation of a patient, and based on the case ID, we can identify the patients. And among the data, there is the epicrisis, the anamnesis, the main complaints, the therapy, which is very important in our study, because also the blood products use is written there. And for gastrointestinal bleeding patients, we can either search for them based on their BNO codes or based on the requested gastroenterology consultation, which is in another Excel sheet. And we have a search table as well. So same with the case numbers. Each row means each row means a patient. And in this Excel sheet, there are the patients collected who had the blood ClotPro test. So for the protocol, we would include patients with acute gastrointestinal bleeding and who had endoscopy within 24 hours. And we would exclude patients without laboratory examinations and who are bleeding for more than 24 hours. So in group A would be patients where ClotPro was performed, and for the matched cohort, in group B would be patients where ClotPro was not used. So the primary outcome, as we've already seen in the PICO, the primary outcome would be the number of blood products transfused, and secondary outcome, we chose the 30 and 60-day mortality and transfusion-related events. So here's a summary of my presentation. For the first project, the planned submission date is May 2023, and for the second one is July 2023. And thank you for your attention.
Hi, congratulations on your presentation. I would like to ask a question in connection of your first project. So you are going to compare many different diagnostic tools, and are you going to compare them finally to each other or to the golden standard, or what are your plans regarding this?
First of all, we are planning to do a pooled analysis on the pooled diagnostic accuracy, sensitivity, specificity, false and negative predictive values, and then we are planning to do a subgroup analysis based on the tests that have enough articles. Based on that, we are planning to do subgroups on each test.
Yes, thank you.
Thank you for your question.
Congratulations to your presentation. I would like to ask about your protocol, and can you explain why are you excluding the patients who are bleeding more than 24 hours, or does it include patients who basically have a rebleeding or so? Or?
Yes, thank you for your question. We would exclude patients who are bleeding for more than 24 hours because we don't consider it an acute bleeding. So we defined acute as a bleeding within 24 hours. But thank you for your question.
Congratulations as well. I would also like to ask regarding the outcomes that you are interested for a second project. Why you decided to measure only 30 days and 60 days mortality and not, for example, in-hospital mortality? Like, what is the reason behind this?
Yes.
Thank you.
The reason, thank you for your question. We chose 30 and 60 day mortality because these data we can gather from the Ministry of Interior, but the in-hospital and ICU stay is a different database. So our Excel sheets don't include these data. But thank you for your question.
Thank you for the great presentation. In your second project, you suggested that this ClotPro was successfully used in trauma, and this may transfer to GI bleeding. What are the similarities and the differences between these two cases, like trauma and the GI bleeding specifically?
Yes, so trauma bleeding, the guidelines in the it's based on the literature. So as I examined it, there is no really meta-analysis or any data about using a closed pro in massive gastrointestinal bleeding. Only they are focusing on trauma patients, and that's why there is only data on trauma and trauma patients.
I'd have a last question. Maybe it's a really silly question, but I had the same question almost, like why 24 hours? I understand this is how acute is defined, but then why focusing on acute? Like why not looking for patients who had 48 hours of bleeding or 25?
That's because they usually, if there is a severe bleeding, they usually present at the ER with an acute bleeding if it's a very severe bleeding. So that's why we defined acute as a 24-hour time limit.